Welcome all. Now the next session post lunch is interventionalist journey into neuro-rehabilitation. I would like to invite Dr. Atulabh Vajpayee sir for the talk and Dr. R.K. Sureka sir and Dr. Kailash Dhankar for the chairing session. I will invite Dr. Sushil Tapadia sir for welcoming and welcome all the chairpersons and speakers.
Thank you, sir.
A very good afternoon to everybody. And after a sumptuous lunch, we gathered for the post-lunch session. And at the onset, I would like to thank the organizers for such a nice program. And now the next speaker would be Professor Atulabh Vajpayee. And he'll be speaking on a novel topic of interventionalist journey into neuro-rehabilitation. So I think it's a very good topic. I'd like to introduce Atulabh ji in a short form because everybody knows he's interventionist. He is professor and head of neurology at Pacific Medical College, and he's got many. His aptitude is towards research, and he's doing a lot of projects of DST and ICMR. Plus, he is guiding some PhD students and is an examiner for neurology, DNB neurology. And he is also running neurovascular intervention programs in Udaipur. So, welcome and please start the talk.
Good afternoon. It's post-lunch. This topic is also bizarre, slightly, as Dr. Sureka was asking me in the beginning, what exactly this means. Interventionist journey into neuro-rehabilitation. So basically, in morning session, we had excellent talks with protocols, evidence-based medicine. These are, slight deviation. I'll be sharing my own experience and work in terms of as an interventionalist. And we all know stroke, despite of whatever best we do, there is residual 50%, some deficit, be it speech related or sensory motor or cognitive or vocational. So some kind of deficit is there. And sometimes we as interventionalists are responsible for additional 2 to 3% also. So how do we actually, so first part of my talk, I'll be trying to just highlight what all I did trying to minimize this handicap in patients. Well, we all know, as very rightly pointed out, this mechanism of stroke, artery to artery emboli, there is a plaque sitting in carotid artery, but it gets embolized. So basically, what detonates the bomb? Of course, we all know. This is very clear. If you have a stenosis like this, and you have an emboli sitting in the middle cerebral artery like this, you recanalize this vessel, and something like this you get. And fortunately, when you recanalize, you retrieve this thrombus mass. So this is what it is. This was, here the work starts. So once I have retrieved this thrombus mass here, it is from a sterile compartment, that's from brain. So when I was trying to look, there are standard risk factors, we all know, hypertension, diabetes, smoking, lifestyle, all these things. But you might have encountered many patients who have none of these risk factors, still they have a stroke or heart attack. So I would say in your practice, you would have many such patients like this. So what explains that? We all know this is unstable plaque, a large necrotic lipid-rich core with an ulcerated fibrous cap and an intraplaque hemorrhage. Most of them are not mobile. Mobile makes it further unstable. So this is unstable plaque. So the thing was, what I was trying to look at, what makes these plaques unstable, apart from standard risk factor, which we all know and read of. This is something when I retrieved this thrombus sample from middle cerebral artery, I subjected them to, this was part of our research project, I subjected them to metagenomic analysis. So metagenomic analysis or new generation sequencing, basically, we all know that if you wipe a swab on your skin, culture will not pick up any infection probably. But if you do metagenomic analysis, even if it's single bacterial DNA is there, it will pick up. So a single bacterial DNA will be picked up by metagenomic analysis. And this was first pilot study we published in neurointervention. And you can see these were initial few patients where we retrieved as high as 27 bacteria. And they were not contaminant. 27 bacteria. All of these were non-pathogenic or low-grade pathogenic. So basically, to speak, they were commensal in and around our body, be it in your gut or oral cavity or in your skin. So they live with us. We all know number of microbiota or these bacteria outnumber our human cells. So it is 10 raised to the power 4 times we have microbiota in our body than our own cells. So how does these bacteria be responsible for any event? So these were the mechanisms we thought of when we proposed these 4 hypotheses to start with. Lactobacillus, very common in our gut, we all know that. We know the beneficial aspect of lactobacillus. But here, lactobacillus, it produces 100 times faster oxidation of LDL cholesterol. And this makes plaque vulnerable. Another mechanism, these bacteria, somehow they are commensal in and around our body and they get somehow transgressed through gut and sit in the carotid plaque. It is not septicemia or frank sepsis. These are non-virulent. So they just get entry and it is through single or repeated bacteremia, they get lodged into carotid plaque. So basically, they sit there, form a mucinous layer over them, and they lie dormant there for years and decades altogether. One fine day, there is tremendous stress happening in the body. There is surge of norepinephrine. The iron gets free from its bound form, and these all things are responsible for this biofilm dispersion, and they get released. Another mechanism, like this is Pseudomonas fluorescens. It is not aeruginosis virulent. Fluorescence is not. Enterococcus. So they elevate factor 8, and there how they make these plaques stable. Sometimes low-grade staphylococcal hominis bacteria, they are usually asymptomatic, but they can produce local inflammation, release TNF, interleukin 8, and all these things, and transform unstable, stable plaque into unstable or a ruptured one. There are indirect mechanisms also. So I'll not go in details of those. So basically, this is one aspect we can look, and this summarizes the various mechanisms and hypotheses which probably makes a plaque unstable. Well, coming to the second point. In morning, we were discussing a lot about CT-based protocol versus MR-based protocol, and I know it's in all the big institutes. It's a standard practice most of the time, CT-based protocol. These were our own data. I was also doing CT-based protocol. Fortunately, in my institute, I have a common console on one side MR, other side CT. So we have perfusion imaging and everything with us. We started doing CT-based protocol. Then we started comparing. The problem here is, as Akish sir was very well saying in morning, economics does matter a lot in our patients. So the patient will ask you, what is the level of assurance you're going to give me, doctor, that patient is going to be better with this treatment if I spend 3 lakh rupees, let's say, for this. So this answer will probably come better from a MR-based protocol. Why? I'll tell you. In the middle of the night, interpretation of perfusion studies and all these things are, in real world, these are not that easy and straightforward. Usually we do MRM. So MRA we do is here 13-minute MRA protocol. CT and MRA, there was difference of 5 minutes. Of course, CT was a shorter time taking. So we compared to the outcome, the MRS at 3 months was much better in MRA-based protocol compared to CT-based protocol. And these were 152 patients here. So it was like 65% MRS, 2 or less at 3 months compared to 35% in CT-based protocol. And in my experience, hardly there was, any patient who was removed from the MRA suite because of motion artifact and all those things. Obviously, if somebody has pacemaker and those things, that's another thing. So basically, this is another thing which we try to, make lesser complication with our endovascular precision selection of imaging. So that is my take. Another thing, because being a clinician, all the time I have been seeing there's been tremendous growth in imaging, CT, MRI, perfusion, I don't know, rapid, what next, I really don't know. Why not to make life simple? Why not to have something like ECG and biochemical marker like our cardiologist colleague do? So I have been working on biochemical markers from last many years, and out of 10 markers we have studied. So this was one thing, cell-free plasma DNA. It's a simple concept. We all have DNA inside neurons. Once there is, stroke is there, blood-brain barrier is breached, and you have release of DNA in the peripheral circulation. So once the level of cell-free plasma DNA rises, so you can actually correlate before you do any of these procedures. It just takes 300 rupees to do cell-free plasma DNA if you have a PCR machine. And with COVID now, every institute, every hospital has a PCR machine. So it is the extent of neuronal injury that will be reflected by level of cell-free plasma DNA. If it is a hemispheric infarct, the cell-free plasma DNA is going to be above 10,000. So here, these are the subset of patients based on a plain CT scan and biochemical marker estimation, you can actually rule them out. So before doing mechanical thrombectomy or even IV thrombolysis, so there is a poor outcome if the cell-free plasma DNA is more than 10,000. Outcome is better if it is less than 10,000. If it is 2,000, be aggressive in management. Probably there is lesser neuronal brunt and you have a lot of tissue to salvage. Simple blood test can give you the answers which a perfusion study or detailed, complex imaging would provide. So this is one thing, and maybe the time will come when biochemical marker will be even better than what it is today. And this is another publication we did. So now we have done almost more than 300 patients like that, and we have published that also. Well, this is very interesting story. In intervention, neurosciences, things have been, as Dr. Khurana was saying, we learn, we unlearn. This was precisely Shakir sir, when he started, he is one of the pioneers in neurointervention in the country. When I was working with him, sir published these more than 100 patients of carotid stenting. That was in 2006. So that time, fantastic results. I know from my experience, sir's complication rate were 3% at that time. But unfortunately, same year I joined a leading institute, and the first seminar, carotid artery stenting, case closed. These two articles virtually, removed carotid stenting as a standard procedure, and now we all know after CREST, things have again changed. So this is really very fluid. So now we know carotid artery stenting is a standard procedure. Another thing, few years later, this was a scan, a small infarct. I was taking patient for IVTP or thrombectomy, but I found there are good collaterals here. So at that time I left. Probably collaterals are good, but 2 days later there is a large hemispheric infarct here. So this impersistence of collateral, you find collaterals are there, you don't intervene. 2 days later your patient gets a big infarct. So what did you miss? So basically, this is again we published these set of patients where I had found good collaterals, I did not intervene. and they had developed big infarct. So basically, sometimes what happens, there is a complete occlusion. You do IV thrombolysis. There is partial thrombolysis of the plaque, which is already unstable. As I said, unstable plaque, it will again probably have thromboembolic showering. It will occlude your collaterals also. So you have to, now the practice has changed. So that is what some cases were shown in the morning that you have to take care of. So don't always believe on collaterals blindly. Well, this is another interesting aspect which I have been looking at carotid stenosis from last 15 years. I really find a 90-degree stenosis. This is not my experience. 30% stenosis, patient in ECST, they had half of the stroke, less than 30% stenosis, half of the stroke. I find, in my experience, 70% stroke patient will have stenosis less than 50%. And these are the patients you do medical management only. So degree of stenosis, probably it matters when there is a hemodynamic component. But it is probably the plaque morphology, unstable plaque, that is responsible irrespective of degree of stenosis. So again, I started looking at these set of patients at in all 160 patients like this. So what I did here was, so what I did here was a plaque which is more than 1.5 centimeter thick. I started looking at bilateral carotid artery stenosis patients with less than 50% stenosis. So basically, these are all less than 50% stenosis. We did plaque morphology evaluation through MRI. I'll skip these. So basically, symptomatic stenosis, intraplaque hemorrhage, ulcerated fibrous cap, lipid-rich necrotic core, and mobile thrombus. These were the features which were present in these subset of patients. And asymptomatic was same patient contralateral ICA. So control was also there, symptomatic side and asymptomatic side. We compared in the same patient. So no need to age, sex, gender, everything matched. So you can see the very much difference. So the future studies have to be, in context to plaque morphology rather than degree of stenosis. Well, coming to the crux of that, based on that, as I said, the motor impairment will be after stroke in 50% of patients, cognitive impairment 20% patients, post-stroke depression around 20%, and dementia, speech impairment, all these things would be there. Well, so basically, neuro-rehabilitation is a process of diagnosis, evaluation, and management of disabilities in patients with neurological disorder. So basically, what you need here, this is daily disability adjusted life years lost, more than 1,000 in lower middle income class countries. These are all various conditions which need rehab. These are the various impairments: physical, cognitive, psychological, vocational, speech, swallowing, bladder, bowel, and sexual impairment. Various model proposed. So this is something, again, I'm not very fond of these kind of models because these things doesn't work in our setup. Every setup, every institute, every place has to individualize their protocols and things. So there are various kind of model proposed, multidisciplinary task care coordination. What we have done, I'll emphasize on that. So basically, neuro rehab team has to be led by a neurologist. Most of the time, neurologist is referral to them. They will refer the patient, and after that, their contact is over, whether neurologist or neurosurgeon. So basically, there's something called rehabilitation physician or physiatrist. Physiatrist means who is expert in rehabilitation medicine. And we have a scarcity of manpower, less than 10 per million skilled practitioners are there in our country. So the whole idea is neurologist has to take lead. Well, there is scarcity of data for rehab professionals also about assessment, rehabilitation interventions. So this you can see here on this side, high income group countries, on this side, middle or low socioeconomic countries. Well, these are things which are online scales available. So recommendation for physiotherapy is 3 hours per day, direct task specific therapy, 5 days a week, delivered by a team of professionals. So these are standard. I mean, there are very few guidelines in rehab, but this is one of the guidelines I'm putting it across. Well, in neuronal plasticity, we all know there are various things which matters: use it or lose it, use and improve it, specificity matters, repetition matters, intensity matters, time matters, salience, age, transference, and interference matters. So what is neuronal plasticity? We all know that. So this is something like, what happens? We all know neuron will not regenerate. There is axon A, there is axon B. So it is, Hebb's law is as old as 100 years now. So one neuron which fires, which is in sufficient proximity to the another neuron, it is electrical impulse. So once it fires, it other one takes impulse. There happens metabolic changes between both two neurons. So basically, the neuron that fire together, that wire together, and this is how neuronal plasticity develops. Like there are two ways only. Either you can have sprouting of neurons, or you can have rerouting. A damaged neuron is there in between. So the two neurons separate apart. In between there is damaged neuron. So they will reroute. So this is how neuronal plasticity principle is. And you have to utilize this principle for improvement of your patients. So basically, you have to screen. It's a, in aphasia, we have this this is another FAST, Indian adaptation of Franchi aphasia screening test, FAST. It is in 5 languages in our country available. There's 4 sections: comprehension, verbal expression, reading, and writing. So this is, we all know, as a neurologist, we have been taught Broca's area, Wernicke's area, and the arcuate fasciculus which connects the two. So from that time, we know that Broca's area, which is adjacent to motor cortex. So there have been some development. We all know you have a non-fluent Broca's aphasia, you have Wernicke's aphasia here, you have a problem in arcuate fasciculus, you have a problem with repetition, impairment of repetition. That's what we call conduction aphasia. There has been some development, like we know about this, but there is something called dorsal premotor speech area, ventral premotor speech area. So what is new here? This dorsal premotor speech area, it is involved in controlling voice pitch during speaking and singing. It codes pitch-related acoustic feature during speech listening. So that is why we call somebody can sing well despite he cannot speak a sentence. So these are 2 different areas. So the dorsal premotor area, so this is what the new theory is. Dorsal premotor area is responsible for pitch, prosody, and song, while ventral premotor area is responsible for oropharyngeal muscle contraction, facial muscle contraction, and there how they produce, speech. I will not go details of this because we have for lexicon, for phonology, for everything, we have a specific area marked. So I'll just skip this. I've already covered this. When the comprehension is for speech, there are 2 approaches. Either it is impairment-based approach or live participation-based approach. So basically, you have to have a speech-language pathologist. Now, but who will decide it? A physiotherapist may not be able to decide that patient needs a speech-language pathologist. So basically, you really have to lead the rehab program. I mean, the whole idea was, again, to emphasize that neurologist has to be leading the rehabilitation program, neurologist or neurosurgeon, because they have to be at least treated properly. Nothing comes alone. They all problems come in package. So what matters? This is called ILAT, Intensive Language Action Therapy. What matters most? Total duration of therapy is spread over weeks or months. It doesn't really work. You do slow, steady, and you keep on doing it for years, and patient bolta mere ko aaram nahi aata hai. So same duration of therapy has to be compressed in lesser number of days. Let's say 1 month after acute stroke. This is constraint-induced movement therapy. Again, 6 hours per day, 90% waking hours. This is for upper limb. Basically, I was talking of speech earlier. Now I come to upper limb. You constrain unaffected limb. Now it is very difficult for patient actually. So now the modified CIMP is 1 hour per day for 3 days in a week or 5 hours per day in the weekend. The minimum inclusion for patient is at least you have to have 20 degrees extension, 10 degree finger extension, and 10 degree thumb abduction. Well, this is virtual reality based program. I mean, this is because as a neurologist, when you see the problem, I developed the whole rehab program in my institute. So this is virtual reality based program. It's very simple, easy. You just, patient has a 0 upper limb power, but they are doing chopping of vegetables, they are slicing fruits, and they really, get positive reward by doing that. In virtual reality environment, you can actually make them to do every such thing. And the even better is they can sometimes get into 3D environment of that is called immersive, semi-immersive, immersive, and non-immersive. These are the 3 type of virtual reality based therapy. So this is another a newer mode of treatment for rehabilitation, for neuro-rehabilitation. So the computer becomes your gateway to virtual world. So this is how in COVID time we learned all. So this is how we started doing tele-rehab. So tele-rehab was because in a larger perspective, if you want to apply this, in the remotest of the area, the only thing we have in our villages even is smartphone. So based on any kind of tele-rehab, if it has to succeed, it will succeed on. So this was almost 193 patients we did tele-rehab. Because the whole idea was, sometimes what happens, you don't have a team of professionals. I would say a neurologist leading physiotherapist, occupational therapist, thirdly, your speech therapist, fourthly, clinical psychologist, which will do cognition as well as post-stroke depression, anxiety, and those things. Because so this is how these four specialties put together under guidance of neurologist or neurosurgeon would do better to your patients. I'll just take a couple of minutes. So this is what our own study showed, and this is actually doable and very effective also. And there are few other studies also from the country. So this is, I'll again not go, those who want to develop, a neurologist can develop actually this basic neuro rehab center right in his OPD only. So this is, you don't have to have, it's just you require 800 square feet of area, and high touch is better than high tech. Even if you don't have high tech equipment and gadgets, you can do that. Standard rehab, around 1500 square feet of area, and basic equipment, you just can have software related things here, because you can have accommodate a computer very well in your OPD also. So this is, and you can get attachment to a nearby hospital. So standard neuro rehab, again, it can be done with one's OPD also. Advanced neuro rehab center, so this requires bigger area, 4,000 to 6,000 square feet area, and it has gadget of everything. There are 5 advancements basically. You have aquatherapy now, you have transcranial magnetic stimulation, you have virtual reality based therapy, you have robotic therapy, you have brain computer interface. So these 5 newer tools have emerged in rehab, which we should take care. So advanced neuro rehab center will have everything. I'll just show you my center. So this is a basic thing. When I started with, I have some balls and gadgets. These are cycles, and this is speech therapist doing manually only. Then you bring in virtual reality based system, and then you bring in robotic system. This was indigenous system, which was not robotic system. Then you have a vertigo lab. I mean, in Jaipur, Dr. Anita Bhandari, she was courteous enough to provide us this vertigo lab. So vertigo rehabilitation is also part of neuro rehabilitation. So this is the new toy we have bought from Russia. So this is how it has. This is the unique one in our country because it has exoskeleton, a robotic exoskeleton. It has a functional electric stimulation also. This functional electrical stimulation is making this patient to take further steps. So these are things I was saying: robotics, aquapool, TMS, virtual reality, and brain computer interface. Super advanced, of course, you combine it with research and education, it will become a super advanced center. Very difficult. These are some indigenous Indian products which are cheap also. Sitar system, very popular, very cheap. Research and education. So this is one of the, sir was saying, one of the PhD student under me, basically he has been doing comparison of conventional physiotherapy vis-a-vis newer neurotechnology tools. So let's say maybe we'll have answer in a couple of years from now. Yoga and music intervention, very interesting. Simple thing you can provide in your lab. We used music clip from Pandit Vishwamohan Bhatt. So he provided a classical music clip. So this study of more than 200 people we did in COVID time, and we extended that further, and that really helped our patients. Based on the need, then this was FINR, which not interventional neurology, it is fellowship in neuro rehabilitation, because we physiotherapists have only experience of physio. Speech therapists will have, they come from ENT side, physiotherapists, clinical psychologists would come from psychiatry department. So they really don't know about neuro rehabilitation. So you have to train a person for a year's time to provide him adequate exposure to speech therapy, physiotherapy. They are from various backgrounds, cognitive therapy, and lastly occupational therapy, which is again very important and very neglected. So this is how I think there is way to go to have manpower, skilled manpower in our country. So at the end, I would say low-cost neuro rehab service is need of the hour. In my experience, tele-rehabilitation may reduce this gap in developing countries like ours, and family-based rehabilitation with tele-rehab can provide neuro rehab services to many who otherwise would be left alone. Thank you very much.
Thank you, Atulabh sir. This was a very difficult topic and untouched topic. Thank you, sir.
Now, I would like to invite Dr. Sureka sir and Dr. Kailash to present an amendment.
Thank you.
Thank you, sir.